Hi, I'm Dr. James Huang. I'm a consultant pediatric gastroenterologist at the National University Hospital. My main clinical and research interest is in pediatric inflammatory bowel disease and endoscopy in children. Crohn's disease is the most common type of inflammatory bowel disease that children have locally. Based on our regional pediatric Asian registry data, Crohn's disease accounts for approximately 2/3 of all the IBD cases we see in South Asian children. This slide shows two things. One is the rapid rise in overall IBD incidence, and Crohn's disease, represented by the blue bar, is the predominant type of IBD that local children have. We also note that about 1 in 5 children with Crohn's disease are first diagnosed when they are less than 6 years old. We call this very early onset Crohn's disease. It is increasingly important to recognize that no two children with Crohn's disease behave exactly the same, and it is vital to personalize treatment strategies so as to treat to target. This is akin to a soldier fighting a battle. A soldier needs to estimate how big, how strong, or how far the enemy is before planning to take aim with his or her weapon. Likewise, with IBD, it is important we determine disease severity right from the start, so we are able to take an accurate aim at the target. This allows us to start treatment timely and with appropriate intensity to match disease severity. How do we do that? We use a scoring system called the Pediatric Crohn's Disease Activity Index to determine how severe a child's Crohn's disease is. Unlike tests and examinations, this is one scoring system you don't want to have high marks for in Crohn's. The higher you score, the more severe your Crohn's disease is. It is scored based on symptoms the child has, findings on physical examination the doctor does, and certain blood test values. Certain features indicate that a child has severe Crohn's disease. Number 1, how bad is the abdominal pain? Belly aches that are disabling and disruptive to a child's daily life is an indicator of severity. Number 2, how bad the diarrhea is. Not all patients with Crohn's disease have diarrhea, but very frequent stools or diarrhea that affects the child's sleep or very bloody stools again point towards severity. Number 3, the presence of extra-intestinal symptoms. IBD can affect parts of the body other than the intestine, hence the term extra-intestinal symptoms. The child may have fevers, swollen joints or arthritis, or erythema nodosum, which you can see. These are painful bruise-like marks that are typically on the shins of a child. The third point for severity is the overall impact on the child's daily activities. Whether or not IBD affects the child's schooling, hobbies, extracurricular activities. If there's greater impact, then very likely this is much more severe. Next point is that of severe weight loss, which is defined as losing more than 10% of your body weight unintentionally. This is a growth chart that you can see, which is familiar to most parents with children. The red arrow shows the typical weight loss experienced in severe Crohn's disease, with weight gain shown with the green arrow after successful treatment of Crohn's disease. The last point about growth: poor height velocity. An average child should grow between the minimum of 4 to 6 centimeters per year before puberty. If they don't, then this is an indicator of severe Crohn's disease. Growth and development are particularly important in children, and it comes as no surprise, Crohn's disease, if it's left untreated, severely affects a child's growth and puberty. In fact, Crohn's disease, as compared to the other type of IBD called ulcerative colitis, is much more likely to have a negative impact on a child's height and weight. Having fistulas also is one of the signs of severe Crohn's disease. A unique feature of Crohn's disease compared to ulcerative colitis is the tendency for Crohn's patients to have fistulas. What are fistulas? These are like earthworm tunnels that burrow through the intestinal wall into neighboring structures of the body. The part of the body we see fistulas happen most commonly is at the perianal region close to the anus, where these tunnels or fistulas can penetrate from the bowel into the nearby genitalia and organs. As shown in this diagram of a cross-sectional view of a person's bum, the fistula or tunnel in this case goes from the anus through the wall of the large bowel, through the fat surrounding muscles, and right out of the bum through the skin. Fistulas happen because the inflammation in Crohn's disease goes much deeper than ulcerative colitis and affects all the layers of the bowel. These fistulas are bothersome because they often get infected, form abscesses, as you can see in these pictures, and cause a lot of pain. Unfortunately, 1 in 5 of our children with Crohn's disease have a perianal fistula at diagnosis. Interestingly, children in Singapore and Malaysia who are of Indian and South Asian ethnicity are more likely to have symptomatic perianal disease at the point of diagnosis. This means these kids first present with either pain around their anus, an abscess, which you have seen earlier, or pus that's actually discharging from the fistula opening onto their clothing or undergarments. These fistulas can be obvious once you examine the bum, but often an MRI scan is needed to determine how complex these earthworm tunnels are beneath the skin. Obviously, the more complex the fistula is, the more severe it is. On the next point of severity, your doctor will typically order certain blood tests in the diagnosis and monitoring of Crohn's disease. I will just focus on a few ones that we use commonly to gauge the degree of disease activity in pediatric Crohn's disease. The first is hemoglobin. This is part of the full blood count test. A low hemoglobin is what we term as anemia, and this correlates with disease activity, meaning the more anemic you are, the more likely your disease is active. The second test we do is called ESR, Euretrocyte Sedimentation Rate. This is quite a mouthful, but this blood marker measures the amount of inflammation in your body and will be high whenever the disease is active. The third test that is done is called albumin. This is a protein found in the blood and tends to be low whenever the disease is active. Besides symptoms and blood test markers, pediatric gastroenterologists are recognizing that certain features on endoscopy, such as very deep ulcers in the large bowel, as you can see here, these features indicate severe disease and potentially poor disease outcomes without aggressive treatment.